Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about autoimmune diseases. Last week, I ended 3 shows on autoimmune hemolytic anemia. Now I'm beginning another autoimmune hemolytic anemia, which is also very common, though I wouldn't be talking about it per se. I just give you an overview of the different things that it can be associated with in terms of the disease. I'm talking about rheumatoid arthritis. Worldwide, 140 million people suffer from rheumatoid arthritis. And in this country, 1 out of every 3 American folks suffer from rheumatoid arthritis. Very, very common. The key why I'm picking on rheumatoid arthritis is because of a condition called overlap syndrome. That is to say, when you have one autoimmune disease, let's say in this case rheumatoid arthritis, which is an autoimmune flash inflammatory disease, and the first thing that they present may not be the most prevalent thing that gives you the symptom, and yet the underlying one may be rheumatoid arthritis. So therefore, when somebody presents with a condition that you think is autoimmune in nature, be it anemia, be it a low white blood cell count, or low platelet, you must think about the possibility of the patient can have rheumatoid arthritis as the underlying condition. Let's take, for instance, low white blood cell count, which is extremely common, more common than you would imagine. As I said, I ended the series last week talking about red cell. In this segment, we're going to talk about rheumatoid arthritis as the underlying condition that can cause somebody to have low white blood cell count as they present. Many, many other conditions can present first with low white blood cell count, such as lupus, rheumatoid arthritis, to give you a couple of examples, Sjögren's syndrome, and I can go on, and or the ethnicity of the individual. Individuals of immediate African ancestry, namely Negroes, have a very high incidence of low white blood cell count. For instance, Caribbean folks who are Negroes, and most of them, of course, are Negroes, the median white blood cell count is 2,600. The normal white blood cell counts start at 5,000 to 10,000. So that gives you an idea right there. There are many, many conditions that are autoimmune in nature that can cause you to have low white blood cell count, or because of your ethnicity. The subgroup with the highest incidence of low white blood cell count are folks that come originally from West Africa. You have to understand that. That's very, very common. And there are a long list of conditions that can cause low white blood cell count, as I just mentioned, rheumatoid arthritis being one of them. So when you see somebody, you're evaluating them for whatever general medical condition you're evaluating them for, they present with aches and pain, and then in the joints, etc., and you're going to evaluate them, think of rheumatoid arthritis as the mother of the so-called autoimmune hemolytic diseases. And if you keep that in mind, that can lead you to major diagnosis. Not only that, that is not to say that rheumatoid arthritis itself is not a major diagnosis. It is. But I'm giving that for you as a template, as it were. And I'll give you an example of a case that I will always remember. Maybe 25 years ago, probably, 25 years ago, I was sitting in my office minding my own business on a Friday afternoon. I got a phone call, long distance phone call, from a lady who called to say someone who knows me that I've been taking care of refer her to me because she's desperate. So I listened to the story. The story went that she's having constant diarrhea. She had lost some 60 pounds or more. She's gone to her local hospital, and I will not name the area in the world, multiple times. No help. She's desperate. She's on disability. She wound up in Atlanta, Georgia, spent several weeks there being evaluated. They can't figure out why she's having lots and lots of diarrhea. They did colonoscopy, they did endoscopy. She continued to have lots of diarrhea. They did all kind of workup. She went back home. In desperation, she wound up in Washington, D.C. at another hospital because somebody referred her there. Again, the same scenario. However, when I listened to her, I asked the question, are you having joint pains anywhere? She said, oh yeah, my joint, my knees, my shoulder, my elbows, ankle, always hurting me, swelling, blah, blah, blah. But I'm also having this massive, so in other words, the main symptom was the diarrhea, but she was having multiple joint complaints. And I said to this is a Friday afternoon, around 3:30, 4 o'clock, and I said to myself, okay, can you travel to White Plains? Patient said, yeah, she and her mother can travel. And I said, well, there's a hotel called Corn Plaza in White Plains. Can you make a phone call, see if you could make a reservation there? If you show up over the weekend, then I can admit you to hospital on Davis Avenue on Monday. She said, sure, she could do it. And I said, fine, fair enough. So I pick up another sheet that has 32, hospital has other sheets that we have 32 orders in there. And I write my orders, and I'm going to walk them over to the hospital that same Friday afternoon for this lady that's coming on Monday. I called the admitting office. The lady is on disability. She's now got Medicare. So they accepted the admission. She's coming Monday morning, and I left the sheets with them. I want you to be aware, on that 32 orders that I wrote on that sheet were her diagnosis. Her diagnoses were right there. He said, well, how come? Well, it turns out that she also had arthritic problem. And on top of that, she's having massive diarrhea. No matter what it is that she eats, it goes right through her within minutes after she eats it. And I said to myself, I bet you she had an endoscopy, she had colonoscopy, those were normal. What else left in the GI tract that hasn't been looked at? I bet you she's got small bowel problem, because that's the only part they haven't looked at. And in those days, there were not that many physicians in the country that were capable of looking into someone's small bowel. Now lots of people can do it. So I said to myself, I bet you she's having some form of arthritic condition and a small bowel condition. And which small bowel condition that can cause somebody to be having more than 100 bowel movement per day? It's got to be the small bowel. Because when you eat food, the food goes to the mouth, to the esophagus, goes into the stomach. It has to sit in the stomach for a while, and then it has to go to the GI tract, to the small bowel, because the digestion of the food is not completed unless it does its thing from the stomach to the small bowel for the digestive process to finish. She cannot do that. That's why she's having this massive diarrhea. You have to understand that this is within minutes. I thought of this, I tell you, I bet you she's got scleroderma of the small bowel as part of overlap syndrome that's causing her to have rheumatological problem. And it so happened that 6 months earlier or thereabout, an article came out in the literature that you could do a blood test to specifically diagnose scleroderma, which is also called systemic sclerosis. People associated scleroderma with the skin condition, where the skin is very waxy and you lost the smooth muscle. That is still so. But Every organ in the human body, it turns out, that can be affected by scleroderma. That's why it's called systemic sclerosis. Putting the joint symptom that she told me about and the fact that the food is passing through, I quickly said to myself, I bet you she's got small bowel disease. And which small bowel disease that can cause you to have the food going through? It's got to be a small bowel disease that destroys the smooth muscle of the small bowel. That was my thinking. And then the small bowel becomes as hard of a hollow tube, the food goes right through. Guess what? This is precisely what she has. I admitted her on Monday. By Wednesday, I got the result. By Wednesday, I admitted her, put on IV fluid, blah, blah, blah. Everything was going through her. And I believe it or not, I sent a biopsy of the skin, even though the skin looked normal. Both the biopsy and the piece of the bowel that was taken came back positive. And the blood test that I did also came back positive by Wednesday for scleroderma. By Wednesday. This diagnosis that's been going on for at least 10 years, this lady's been suffering. By Wednesday, admitted on Monday, by Wednesday, the diagnosis was established that this lady has scleroderma of the small bowel. Started her on intravenous steroid and Cytoxin. By the weekend, she was down to 3-4 bowel movements per day. And then the story took a very ugly professional turn that is not comfortable for me to discuss with you, but I'll give you a hint. She came in, this is now for students, because the students do listen to the show. And I also know that colleagues of mine do listen to the show that know exactly what I'm talking about. When she came in, she was totally, completely malnourished. But her BUN, blood neuronitrogen, was 21. After I hydrate her, which I started on Monday, by the time Thursday, Friday comes around, actually by the time Wednesday comes around, her BUN was less than 3, which fit the fact that she was totally malnourished, but she was markedly dehydrated. And the individual that was in charge of the medical department at the hospital on Davis Avenue felt that somehow I didn't know what I was doing because he's never heard about this diagnosis. Therefore, I must be wrong. Fine, minding my own business. My patient is getting better. I'm happy. The patient is happy. It so happened that I got a phone call by the chief administrator of the hospital, the CEO office call, that they need to meet with me at 11 o'clock on Monday. Fine. What do I know? I'm minding my own business. I'm by myself. I've been involved in a lot of political, racial issues at that hospital. It so happened that Monday I started seeing patients. I got a phone call. A phone call from the chairman of gastroenterology at Mount Sinai Hospital in New York City. And the chairman said to me, Dr. Alcena, first of all, before I say anything, I want to congratulate you for making this extraordinary million diagnosis. I said, sir, what diagnosis is that? He said to me, you don't know? I said, no, I don't know. You don't know that you were reported? No, I don't know. He said, well, I review cases for an outfit called IPRO. In those days, IPRO was just about one of the most powerful outfits as it relates to medical supervision in the state of New York, other than the health department. They could actually take point of your license. So I was reported by the hospital on Davis Avenue, by whoever was running medicine, to IPRO unknown to me, until I got this phone call because I was not supposed to know what I was doing, even though the patient is better. To make it even worse, the most outrageous thing they did, they canceled the patient's Medicare benefit, because the hospital can do that. Because they don't care, they don't feel that the diagnosis or the patient being managed. So this lady was going to have to pay the hospital bill because I canceled it. This is how mean and dangerous this was. This is poor lady who hasn't been working for almost 10 years. She was going to be settled down with hundreds of thousands of dollars to pay for the hospitalization unless she leaves the hospital. Well, the chairman said to me, "You were reported. I reviewed your case. It's an extraordinary, brilliant diagnosis, and I also want you to know that I reinstituted the patient's Medicare benefit." I said, "Really?" I never heard such a thing until it was just brought to my attention that the hospital can do that. Okay? This is this black lady who showed up at the hospital coming from somewhere else, another part of the world, and I brought her here. They accepted her. They were going to cancel her Medicare, and she would be saddled with the bill. Okay, I said, "Thank you very much." I listened to the story, fine. I said, "Thank you to the chairman." And then at 11 o'clock, I show up to this meeting. When I got there, the president and CEO of the hospital was sitting there, like God in heaven. He's sitting there waiting to me to cut my neck off. The chief of medicine was sitting there. And the doctor who was in charge of quality insurance was sitting there. And there was an empty chair. You can't make this up. There's an empty chair for me to sit down in front of these fools. And they were really jackasses. But I have to sit there to listen. These are not academic doctors. They're not teaching anywhere. They don't know one-third of what I know. And I'm supposed to sit there, listen to this fool who are about to punish me. And of course, I never sat on the chair. I said to them, "I just got a report for you from the chairman of GI from Mount Sinai that tell me to tell you that you're a bunch of S-head. You don't know what you're talking about." And I walked out. We never to this day have another conversation about this case until the fact that I received a letter a couple of years later on a Christmas, a handwritten letter, this lady praising the hospital, praising the nurses for the high quality care she received, praising me for the care. Hospital to this day has not given me a copy of that letter. I have the letter only because the lady mailed me a copy. You can't make this up. This happened right here in the city of White Plains, not Mississippi, not in the moondog of Alabama, right here on Davis Avenue. And the reason why I was able to make the diagnosis, frankly, because I'm an academician. I'm a medical educator. It's my role to read. And I read the article that said there's a blood test. And sure enough, I did the blood test, came back positive. The biopsy was positive. To this day, the lady's life is saved. She's doing fantastic. She's off the steroid. She went back to work. And it was the joint pains that she also had rheumatoid arthritis. And nobody, of all the people that never realized that this lady has overlap syndrome, namely, she's got rheumatoid arthritis in conjunction with systemic sclerosis, i.e. scleroderma of a small bowel. I want you to understand, she went to Atlanta. She went to Washington. She spent weeks and weeks, months in a hospital in the place where she came from. And within less than a few minutes on the telephone, I was able to make that diagnosis, okay? So therefore, this is what I mean when you have rheumatoid arthritis is a bad disease itself, but rheumatoid arthritis can be associated with a long series of other diseases that you have to keep in mind. When somebody is having joint pain, it's not always due to osteoarthritis. It can be, but 140 million people in the world have rheumatoid arthritis, and rheumatoid arthritis may not just be rheumatoid arthritis. It just may be the template for what's called mixed connective tissue diseases. As an example, I just give you this case, which was what that was. Once I had the joint pain, I had the diarrhea. That's all I needed to hear. And the red flag was up just like that, and I was able to save this lady's life. So what I'm saying to you is that when somebody shows up in your office, they have neutropenia, namely low white blood cell, which is extremely common. I mean extremely common. You have no idea how common that is. You have to look it up. even if the person is a Negro individual, because, in fact, lupus is more common in black folks. Rheumatoid arthritis is more common in black folks. Okay? But it may not be just low white count because of your ethnicity. It may be low white count because you're also suffering from an autoimmune disease such as sarcoidosis, Sjögren's syndrome, rheumatoid arthritis, scleroderma, and on and on and on. So that's what I told you when I say I'm going to do this series on autoimmune diseases. I'm not just going to sit here, and I just copied this, by the way. This is chapter 79. I copied from this big book that I wrote in 2016 on rheumatoid arthritis. So you have to understand, the rheumatoid arthritis can affect the feet, the ankles, the hands, the fingers, the elbows, the wrist, the shoulders, the hip, the neck, lumbar spine, thoracic spine. Okay? And look at all the different organs, the heart, the lung, the brain, blood system, kidney, the GI system, neurological, all these things can be associated with it. And that may be the way they present. The problem may be presented not just as joint pain, it may present as something with your heart, may present with something with your lungs, could develop problem, and it may all be part of this autoimmune syndrome that either rheumatoid arthritis, scleroderma, sarcoidosis, dermatomyositis, Sjögren's syndrome, all these things can be why the person present. But don't think that's all it is. Okay? So when someone then shows up, let's take the example of white blood cell count. That's low. The normal white blood cell count is between 5,000 to 10,000. Let's say somebody, I have people in my office with white blood cell count 1,500, 1,200. And I evaluate them for everything else. They don't have anything else. That's the problem. That's the ethnicity. So you have to know how to manage this individual because they are at risk of developing all sorts of infection. But that's who they are. Your white blood cell count is going to go up if you make it go up under certain set of clinical conditions that require that you do so. The key thing is to evaluate. You have to be a thorough evaluation. You take a history from the patient. You make sure the ethnic background, what kind of work they do, what kind of other diseases they may have had in the past, or you take the symptoms very carefully. You examine them completely and thoroughly because autoimmune disease can affect all part of the body, from the eyebrow to the hair that can cause alopecia, to the toenail, to the fingernail. And I'm serious. Then, after your thorough examination, take a look at the spleen. Is the spleen enlarged? Because an enlarged spleen can cause you to have low white blood cell count, low red blood cell count, low platelet, all three at the same time. Is the liver enlarged? An enlarged liver can also cause some of this problem to occur. Can cause anemia, can cause low platelet, and can, of course, cause low white blood cell count. So the abdominal exam is very crucial. Listen very carefully to the lung. The lung may have condition in it that can be part of the autoimmune process. Do a thorough neurological examination. After you've done all that, look at the skin very carefully. When you do all that stuff, look at the eyes. There are many, many autoimmune diseases that can affect the eye. That can present first with the eye as the first place the symptom begins. And subsequently, other organ can get it. Take nothing for granted. After you've done all that, get yourself an EKG, get yourself a chest X-ray, get yourself an abdominal CAT scan to make sure all the organs are of the normal size. There is no nodes or mass in there that can cause problem. Then you're going to go ahead and do a series of blood tests. Obviously, the blood count. That's how you find out the white count was low to begin with. Complete chemistry profile. Very crucial. Evaluate the thyroid. How do you go from low white count to, well, patient may have Hashimoto's. Hashimoto's is an autoimmune thyroid disease that can be associated with the low white count. It may not cause the low white count, but it can be part of the overlap syndrome. More than one autoimmune diseases can be presented to you. Okay, now that's your white count done. Make sure you check the platelet, because the platelet may be low at the same time. You check for anemia. That can occur at the same time too. And what type of anemia? We talked about that last week. At a glance, you could tell pretty much what kind of anemia it may or may not be. Do a reticulocyte count. And then, most important of all, you're going to do an ANA. The ANA is a broad spectrum evaluation of autoimmune diseases. And send yourself a rheumatoid factor, because the patient may have rheumatoid arthritis he or she did not know. The rheumatoid factor will become elevated. Send blood tests for scleroderma. I have a sheet here that has about 200 tests on it. All these tests are there. You have to check them off. You do your sedate. The sedate is crucial, because you cannot, let me repeat that, you cannot have an autoimmune disease of any type without having an elevated sedate. Because the sedate, all autoimmune diseases are inflammatory in nature. And all inflammatory disease or all chronic infection will cause the sedate to become elevated. And then, of course, once you get your sedate, you get your ANA out of the way, you get your rheumatoid factor, you do an evaluation for sarcoidosis, okay? There's a blood test for that. Angiotensin-converting enzyme inhibitor, you do that. And you do all this stuff, you get yourself a urine analysis, take a look for protein in the urine. Because all these autoimmune diseases can affect the kidney, and one of the first indicator of that may be the patient is having proteinuria, putting a lot of protein because the kidney is being damaged and so on by the inflammation. You get all that stuff done, and then you get the CAT scan that I mentioned that, you get your sedate, your ANA, and then you're going to have to decide what to do. Do you have to do a bone marrow aspiration, bone marrow biopsy? We don't know that yet. Listen, I'm going to stop here. I'll continue the discussion next week. Until such time, keep watching this show. This is Dr. Alcena saying so long and bye-bye.